next speaker, Dr. Ravi Kumar Aluri. He will be speaking on optimization of PCI using FFR in acute coronary syndrome in AMI patients. Going now. Thank you. No, it's not coming.
This is a wrong presentation.
Yes, change it.
Yeah, someone who is preloaded, I think that would be better.
Everyone, sorry for the inconvenience. So, acute MI ACS situation, we all know primary PCI is the preferred strategy. But the issue is where lies the dilemma? See, infarct artery totally occluded, you do a primary PCI, and this sort of a picture with critical lesions there in the LAD and LCX, you don't have any doubt regarding that. You want to do it either during the same sitting, that is during the same index procedure, or you want to stage it and do it after 2 days. But a situation like this, acute MI, LAD is totally occluded there, and you see borderline lesions in the RCA, probably 50 to 60%. Do you want to do the procedure? I mean, do you want to do an intervention, or you want to assess the inducible ischemia, or you want to do an FFR and then decide? So that is the dilemma. So has FFR been studied in STEMI? Yes, 2 major trials have come up in the last 2 years. One is the Dynamic 3 Promelty trial. A total of 627 patients who underwent primary angioplasty, they have been randomized to receive either standard care, that is a PC of the infarct-related artery only, or complete FFR-guided revascularization 2 days after the index procedure. The primary endpoint was all-cause death, non-fatal MI, and ischemia-driven revascularization, and the second endpoints being cardiac death, non-fatal MI, urgent PCI, and non-urgent PCI. So if you look at the primary endpoint, there was a 44% risk reduction in patients who underwent complete revascularization. And it was mainly driven by a 69% relative risk reduction in ischemia-driven revascularization. So these are the Kaplan-Meier curves which show a 44% relative risk reduction in patients who underwent complete revascularization. So what are the key takeaways from this? Patients receiving standard care, that is a PCI of infarct-related artery only, were over 3 times more likely, 17% compared to 5%, to return for unplanned angioplasty or bypass surgery than patients receiving FFR-guided revascularization. Okay? And 40% of unplanned angioplasties were considered urgent revascularization. So complete FFR-guided revascularization of multivessel disease in STEMI patients, it resulted in a lower risk of the primary composite endpoint, that is all-cause death, non-fatal MI, and ischemia-driven revascularization, as compared to the standard care. So Thomas Engstrom, the lead author, according to him, what he says is it is safe to do a complete revascularization in this particular patient population. And although complete revascularization should be recommended, any condition that makes complex PCI unattractive may support a more conservative strategy of IRE PCI only. The second major trial has been the Compare Acute, which was published in NEJM in last year itself. Here the complete revascularization with giants was compared with the angio-guided culprit only PCI in multivessel disease STEMI. Basically, it's a multi-center prospective randomized trial. Here, 885 patients who underwent primary angioplasty of the infarct-related artery were randomized in a 1:2 randomization, of which 295 patients underwent FFR-guided complete revascularization, and another 590 patients were subjected to infarct-related artery only treatment plus blinded FFR. And they were given a window of 45-day treatment window where they can choose to get an angioplasty or a CA which is done after 45 days. So the follow-up was at 30 days, 1 and 2, 3 years. So the primary endpoints, as usual, the composite of all-cause death, recurrent MI, recurrent revascularization, and CVA, all MACE at 12 months follow-up, and the second endpoints were the primary endpoint at 2 and 3 years. So the endpoint education, elective clinically indicated revascularization was performed within 45 days after the primary PCA procedure. They were not counted as an event. And DSMB provided advice on premature stopping or continuing the trial based on the interim safety data. So there was no significant difference between the FFR-guided complete revascularization group or the infarct-related artery group in the baseline characteristics, except that the contrast load and the procedure time was more in the group undergoing complete revascularization. So this is showing the randomization and the FFR measurements. What they found was there was a 65% relative risk reduction in patients who underwent complete revascularization as compared to infarct-related artery only treatment. So as you can see, the primary endpoint MACE came down by 65% relative risk reduction, and it was mainly driven by reduced, 68% reduction in the revascularization, ischemia-driven revascularization. And even in the secondary endpoints, the NACE, there is a net adverse clinical events. There was almost like 75% relative risk reduction, with the p-value being significant there. So the Kaplan-Meier curves clearly show that there is a 65% relative risk reduction, and from these data, the conclusions that they have arrived at is approximately half of the lesions in non-infarct-related arteries considered significant on coronary angiograms. They had an FFR value of more than 0.8 and they were not physiologically significant. And differing treatment of angiographically significant coronary lesions in non-infarct-related arteries with an FFR of more than 0.8 is safe and efficient. In multivessel STEMI patients, FFR-guided complete revascularization of the non-infarct-related lesions in the acute phase of primary PCI significantly reduced the risk of complete MACE outcomes as compared with the strategy of infarct-related artery-only treatment. This reduction was mainly driven by the decreased need for subsequent revascularization. So this is just to show a case where the patient present with an inferior MI, the RCA totally occluded. You can see ramus tight stenosis there, and LED seemed to be borderline in the caudal views, and primary PCF RCA was done, and after 48 hours FFR was done to assess the lesion significance in ramus and the LED. Surprisingly, ramus lesion was also found to be insignificant. The FFR value was 0.88, and the LED lesion also, the FFR was 0.88, and they were left on medical management. Thank you very much.
Thank you. I think that was a nice presentation on FFR, when to, how to strategize post-MI patients with multivessel disease. So we'll have some discussion at the end, please. Next talk, I think, is by Dr. Ziad Ali. Is that correct? Dr. Randy Matthew, is he here? He's not here. So Dr. Ziad Ali, he's going to tell us about the when and how to use OCT to improve procedural outcomes in PCI. So Dr. Ziad, please.
HDMI? Fizzy. SD. VG is okay.
Great, thank you very much. So for this next 15 minutes, we're going to focus on how, when, and why to use intravascular imaging in the cath lab. So the first question is how? And the problem really begins at this stage with intravascular imaging. If you look at it as in its totality, it's actually extremely complicated. There are terms thrown around like grayscale and minimizing artifact, sheath material, pulse shape, pulse duration, and length. But these terms are really for the engineer, not for the interventional cardiologist. Instead, imaging for the interventionalist is actually extremely simple and divided into three straightforward protocolized approaches. The pre-intervention assessment, where we assess the plaque composition, identify the reference segments, and choose the stent size. The stent deployment, where we deploy from normal to normal, and then determine our expansion, and then the complications and post-procedural assessments, looking for problems in the stent and problems in the edges. So the benefit of assessing plaque composition in the current era of intravascular imaging is the ability to see all layers of the artery wall. Here you can see an OCT and high-definition IVUS of 60 megahertz showing all three layers, and the ability to detect these layers allows you to make decisions with regards to image interpretation. When the external elastic lamina or media and the adventitia can be visualized on OCT, this is a normal artery or fibrous plaque. If there's a signal change present in the lumen or the wall, if it's in the lumen and it's high backscatter, meaning most of the light is attenuated, this is red thrombus, but low backscatter is white thrombus. If the signal change is in the wall and it's high backscatter, this is lipidic, meaning the lipidic plaque is absorbing all of the light. If it's low backscatter, this is calcification, more as though the light hits something like a crystal and then refracts. And if you want to know which one of these it is, if you ask yourself, can you draw an outline around this signal, this helps identify whether it's low or high attenuation. And so OCT image interpretation as a result can be very simple and divided into these 4 or 5 relatively simple parameters that can guide intervention. And I think that's one of the advantages of OCT over IVUS, where image interpretation is much easier due to the improved resolution. For example, you can see that dissections are much more difficult to identify using intravascular ultrasound than by OCT because of the superior resolution. And does it really matter? Does the plaque morphology matter? Well, it does, because you can see that in direct stenting approaches, you may have an improved outcome, whereas if you identify moderate to severe calcification, treating patients without adequate vessel preparation can lead to very poor outcomes. The next thing to do is identify the reference segments. So the angiogram is severely limited in these situations. Why? Because where we normally land the stent in the proximal or distal reference by the angiogram, there's usually a significant amount of plaque burden by the IVUS. The OCT eliminates this, and the way it does it is by identifying for you on an automatic measurement where the real lesion is, and allowing you to look at the cross-section of the artery to determine whether or not this would be a place where you would normally want to land your stent. Here at the distal reference, you can see lipidic plaque, and as a result, the stent should be moved distally until a more normal segment of artery is identified. Of course, the other thing with vessel and normal reference vessel segments is being able to identify whether or not it's normal. And one of the advantages that has been postulated in the past is that it's easier to see on intravascular ultrasound the entire vessel, but not on OCT. But actually, in reality, this is not the case. In a randomized controlled trial, we identified the reference segment, the ability to detect the border of the vessel, in the same percentage by IVUS and by OCT. But here's the problem. The problem with IVUS currently has been that despite using the intravascular imaging, we haven't been able to co-register it to the angiogram. And after doing your pullback, we land in the position where am I? Am I close to the septal? Am I close? How far am I away from the septal or from the diagonal? Where should I actually land my stent? And the advantage of OCT, of course, is that angiographic co-registration allows you to look at the artery from the outside in and the inside out with great precision. Here you can see angiographic co-registration, which identifies the lens of the OCT, allowing us to look at the artery in great detail, ultimately performing stenting within a standard deviation of 1 millimeter of geographic miss. What about choosing stent diameter? Well, let's look a little bit about IVUS and OCT so far. The first randomized controlled trial of IVUS versus OCT-guided PCI was performed in only 70 patients in a crossover design. And what happened in this situation is that stenting was performed according to the vessel wall, and OCT was performed according to the lumen. And if the lumen could not be clearly identified, according to the angiogram. So you can see in the OCT arm, it's decided by angiography in 37% and only 63% by the lumen, but by IVUS, it's decided by the wall 100% of the time. And strictly as a result of a change in the original sizing, you can see that the IVUS leads to a significantly increased stent area compared to OCT. The stent deployment pressures, post-dilation, and post-dilation pressure were also significantly higher. Illumian 1 was an interesting study of registry design where FFR and OCT was performed in every single case, and we found some interesting things similar to what was presented earlier with the ripcord study. But one of the most interesting findings of Illumian was in fact that in 31% of OCT cases led you to choose a smaller stent size. Now, there's very few situations in interventional cardiology where we should be planning to use a smaller stent diameter. The only one that I can think of is to try to prevent making a hole. So if we look at this in more detail, we find something very unique. In the Illumian 1 study, you could either have pre or post OCT imaging, post only, or a combination of the above. And you'll notice in those patients who had no OCT imaging compared to those who had OCT before and after, the stent is significantly larger in the no OCT group. And what that's telling us is that the OCT is so accurate and precise that it's even more accurate than when you were trained by your trainer about what size a stent actually is. What do I mean? This is a case from Illumian 3 where we performed quantitative coronary angiography and identified the reference vessel diameter of 2.4 millimeters. At the same time, if we perform lumen-guided PCI, we have almost exactly the same numbers. But if we're going to use the lumen, then why not just use the angiogram? What advantage does the OCT have in that situation? And this is the reason why it's been difficult to prove improved outcomes in simple, straightforward patients using intravascular imaging. But let's take a different example where OCT-guided lumen stenting can be deleterious rather than neutral. Here's a reference vessel diameter on coronary angiography of 2.6 millimeters, but on OCT, the lumen is actually only 2.25, and the vessel wall is 3.25. And a vessel-guided approach would lead this to be 4.3 millimeters squared larger. So by the take-home message is you do not size the stent by OCT using the lumen. It must be done according to the wall. Why? The reason is because if you use the wall, you put in a bigger stent. And that's the hallmark of a long-term success for PCI. And I've shown this slides before, but ultimately the other difference is that IVUS compared to OCT oversizes the artery. OCT is precise and accurate, and the result of this is clinically impactful. So if we have a histologically 3 millimeter vessel, the OCT tells us it's a 3 millimeter vessel, but the exact same patient, imaged exactly the same time by IVUS, the IVUS tells you it's 3.3 millimeters. As a result, you choose a larger stent diameter. The larger stent diameter leads to a better outcome. And size, in fact, does matter. The longer the stent and the smaller the diameter, the less likely you are to have a successful outcome. Second generation drug-eluting stent technologies taught us that a minimal lumen area of 5.3 was ideal. Well, actually, that's not the case. This is really the point at which the sensitivity and specificity cross over, and it's not until you get to about 6.8 millimeters squared where you plateau on the benefit of imaging guidance. This is the OCT Lumen 3 stent sizing algorithm, where we focus on using the external elastic lamina rather than the lumen to guide sizing. And here you can see an example of external elastic lamina guided stenting. The OC tells you exactly how long the lesion is, and as a result provides optimization. This is why choosing OCT by the external elastic lamina is the only way to compete with IVUS. Assessing stent expansion is also critically important. There are multiple methods to do this. By biological vessel tapering, we divide the stent in half. The advantages of OCT compared to IVUS in this situation, of course, that OCT provides automatic measurements. How do you do this? You do this by simply placing your reference segments at the area of your interest, and all of the measurements are automated. Here you can see the minimal lumen area in your stented segment and the respective reference or residual diameter stenosis. And so you can do this for the entire stent length extremely rapidly and quickly. Angiographic Co-registration allows us to therefore do this with extreme precision, identifying our reference segments at a great degree of detail. So what did Illumian 3 teach us? Illumian 3 taught us that the post-PCI minimal stent area by OCT only matches IVUS if we use an external elastic lamina guided approach. But we also learned that secondary endpoints, which included the minimal stent area, minimal stent expansion, mean stent expansion, were all better with imaging guidance compared to angiography guidance, and you are more likely to achieve optimal expansion using imaging guidance than by angiography alone. Here's an example of where an angiogram misses an edge dissection. This is a patient who has a distal RCA lesion, and you can see that on the OCT, which was done to perform expansion, you can see that there's a significant intramural hematoma. And these types of hematomas actually are what are clinically relevant. An intimal tear is unlikely to cause a clinical significant impact, but a medial dissection and intramural hematoma clearly need. Dissections were significantly more common in the IVUS group compared to the OCT-guided arm. And in fact, even in the IVUS-guided arm, OCT detected 24% of dissections that were completely missed by IVUS. Why is this important? It's important because this is an independent predictor of drug-eluting stent failure or problems with the edge. Apposition is also easy to determine with OCT. There's an automated apposition indicator which identifies for you exactly where the malapposition is. Again, major malapposition was more common in IVUS and angiography arms compared to the OCT-guided arm. And in the IVUS arm, the final blinded OCT detected missed malapposition in 20% and major missed malapposition in 7%. Tissue protrusion is also significantly more commonly missed by IVUS compared to OCT. So when should you use this? I'll end this in my last 2 minutes. When should you use intravascular imaging? Well, really, you already know which patients are the most likely to have a target vessel failure. If I went around the room and asked you which patients are most likely to have a stent failure, you would tell me diabetes, end-stage renal disease, previous stent failure, comorbidities necessitating the use of bare metal stent. And if we look at the risk factors for restenosis, you can see exactly which patients are most likely to benefit from imaging. And why should we do this? Because if you use intravascular imaging, you improve clinical outcomes. Not only in complex patients, in simple patients, all patients have a benefit from intravascular imaging guidance. So, in conclusion, angiography clearly has limitations. Intravascular imaging has become an integral part of interventional cardiology, and the choice of imaging modalities is dependent upon the lesion and the question to be answered. Thank you very much.
Thank you, Dr. Jihad Ali, for your excellent presentation. We'll have discussion in the end. Lot of questions for you. And then I'm sure OCT is a hot topic here also. And